All right, I am recording. This is video 3 in the 6-part video series on hemodynamics and circulatory shock. My name is Lexi Graham, and in this video we're going to be talking about distributive shock. Most prevalent subcategories of distributive shock include septic shock, neurogenic shock, and anaphylactic shock, and those are the 3 main ones we're going to be talking about in this video. So physical exam findings, these are more of the cardinal signs. So you'll have a change in mental status, a heart rate greater than 90 beats per minute. You're going to want to note that heart rate elevation is not evident if the patient is on a beta blocker, though. Hypotension, respiratory rate greater than 20 breaths per minute. Extremities will be frequently warm with bounding pulses and increased pulse pressures in early shock, and then late shock may present with a critical organ dysfunction, hyperthermia or hypothermia, and then a pulse ox will reveal hypoxemia, and then a decreased urinary output. Clinical symptoms. So if you have an underlying infection, such as this can lead to shock, such as pneumonia, UTI, intra-abdominal infection, and gangrene or soft tissue infection. If you have TSS or toxic shock syndrome, which is the most common type of distributive shock, you may have a high fever, a diffuse rash with skin shedding on the palms and soles over a subsequent 1 to 2 week period, hypotension, and evidence of involvement of 3 other organ systems. TSS is more frequently present with focal soft tissue inflammation and is less commonly associated with diffuse rash. Occasionally, it can progress explosively within hours, though. Anaphylaxis. So that's more of an allergic reaction. You'll have respiratory distress, wheezing, and then uricarial rash and angioedema, or uricarial rash angioedema. And then there's also an adrenal deficiency that can cause hyperpigmentation of skin, oral, vaginal, and anal mucosal membranes. And that is present in a chronic adrenal insufficiency. And then in an acute on chronic adrenal insufficiency can be brought on by physiological stress. Hypotension may also be the only physical sign. Imaging studies. So you can do a chest radiograph. This is the initial imaging for patients with suspected or confirmed sepsis and cough, dyspnea, or chest pain. Computed tomography or CT scans have been the best test of choice for suspected intra-abdominal causes of sepsis. Consider abdominal sepsis. Consider abdominal and pelvic scans with contrast if these sites are found to be clinically suspicious for infection. And then ultrasound. So you can do ultrasonography. This is very useful to assess for cholestasis, biliary dilation, and fluid collections around the gallbladder or head of the pancreas. Ultrasonography / echocardiography may be performed at the bedside in a chronically ill patient to evaluate cardiac function, fluid status in response to hemodynamic intervention, and to exclude cardiac tamponade. And so in these photos, this one is a patient with septic shock. The CT scan shows a septic pulmonary emboli right here, and then intra-abdominal sepsis is shown in this ultrasound right here. You can also actually do a lumbar puncture without any other apparent source of infection for unexplained neurological findings with a patient with a patient with sepsis. And then for hemodynamic monitoring, you're going to be using that Swan scan catheter again. So these values I did them for all 3 of the shocks. So septic shock, CVP will be normal or slightly elevated. Pulmonary capillary wedge pressure will be decreased. Cardiac output will be normal or high, and systemic vascular resistance will be decreased. And then in neurogenic shock, these will all be the same as septic shock, except the cardiac output will be decreased. And then in an anaphylactic shock, the CVP is normal or slightly decreased. pulmonary capillary wedge pressure is decreased, cardiac output is elevated, and then systemic vascular resistance is decreased. So medication options. The initial treatment will be with antimicrobials and should be broad, aiming to pinpoint all possible suspected sites of infection. When choosing this agent, you want to include history, suspected site of infection, comorbid disease if present, and then susceptibility of pathogens within the hospital. IV fluid should be given immediately to help with hypotension. Vasopressors such as Levophed should be administered if IV fluids have not increased blood pressure or cardiac output. Corticosteroids can be used also. Hydrocortisone is the corticosteroid of choice in shock. It may be given to hypotensive patients who are poorly responsive to fluid resuscitation and vasopressors. Antibiotics, they can be given to treat infection once the source and type of infection are determined. And then subcutaneous epinephrine can be given if patients are in anaphylactic shock. ABG anomalies. So if a patient is in septic shock, a high anion gap metabolic acidosis is the dominant blood gas anomaly. Fallen lactate levels over the first 5 days of admission is a good prosogenic marker of survival. So the evolution of the blood gas profile over time suggests that a fall in lactate levels and rise in bicarb levels correlate with a better outcome. And the role of the anion gap prosogenic marker holds promise, and further studies are needed in this regard. So if you have a fall in lactate levels sooner than later, then you have a better outcome with this type of metabolic acidosis. Mechanical ventilation. So assist control mode is preferred and tolerated best. The tidal volume is recommended at 6 milliliters per kilogram of predicted body weight. You want the plateau pressure to be at the upper limit of 30 centimeters of water pressure. You want them in semi-Fowler's position to prevent aspiration, attempt weaning trials, and then you should prone the patient with sepsis-induced ARDS if the PF ratio is less than 150. And you should also avoid high-frequency oscillatory ventilation in adults who have developed sepsis-induced ARDS as well. Because remember, we want to do protective lung. Positive pressure concerns with distributed shock. Of course, venous return, worsening hypertension, right ventricular dysfunction. You want to avoid overdistension. You want to use minimum PEEP levels to avoid hemodynamic instability and ventilator-induced lung injury. Also, you want to closely monitor if high PEEP is needed, and protective lung is always key, like I just said. So in summary, we talked about physical exam findings. They could have an altered mental status, heart rate greater than 90 beats per minute, respiratory rate greater than 20 beats per minute, hypotension, hypothermia or hyperthermia. They could be hypoxic, decreased urinary output, and then, So we also talked about imaging. You can do chest radiographs, CT scans, ultrasound, and a lumbar puncture for the neuro patients. Medications, you can use antimicrobials to start with, a broad spectrum of those, IV fluids, vasopressors, antibiotics, corticosteroids, and sub-Q epi for the anaphylactic patient. We also talked about hemodynamics. So remember, septic patients, the CVP will be normal or slightly elevated. PCWP will be decreased. Cardiac output will be normal or elevated. And systemic vascular resistance will be decreased. And then that one goes over to the neurogenic shock. Those will all be the same as septic patients, except the cardiac output will be decreased. And then with the anaphylactic patients, the CVP will be normal or decreased. PCWP will be decreased, cardiac output will be increased, and systemic vascular resistance will be decreased. Also, we talked about the ABG findings. It'll be the metabolic acidosis with the elevated lactate levels, but of course, if those lactate levels decrease significantly within the first 5 days, you have a better prognosis in the end. And then mechanical ventilation, of course, assist control, plateau upper limit of 30 centimeters of water pressure. You want optimal PEEP, protective lung, making sure we're not overdistending the patient, proning them if they are needed, if that PF ratio is less than 150, and then and overall concerns, you just want to make sure that we're not making them worse with all that pressure that we're blowing into the lungs. We don't want to make their hypertension worse and overdistend them, and you don't want to cause right ventricular dysfunction or anything like that. So that is all I have for this video, and thank you for watching.